Welcome to MenopauseWize, your go-to podcast for all things evidence-based in the menopauseverse. I am Dr. Sukhpreet Patel, an MD gynecologist, a menopause health advocate, a postmenopausal woman, and the founder of MenopauseWize. And I'm so excited to have you join us on this journey. Whether you're a healthcare provider looking to stay on top of the latest evidence-based practices, a woman navigating your own perimenopause or menopause journey, or a partner or family member eager to support a loved one, this series is designed with you in mind. Our mission through MenopauseWize is to close the menopause knowledge gap by bringing you the latest research, expert insights, and practical advice, empowering you to make informed decisions about menopause and perimenopause. Hello and welcome to today's episode of the MenopauseWize Podcast on hormone therapy after breast cancer. What does the evidence say? Where I'm joined by Dr. Corinne Menn. Dr. Menn is a board-certified OB-GYN and Menopause Society Certified Practitioner. She is also an over 24-year survivor of breast cancer and premature menopause, a BRCA carrier, and uses her experience to help women navigate their own health challenges. She has dedicated her medical practice to menopause management, the unique healthcare needs of female cancer survivors, and those at high risk for breast cancer. Now practicing exclusively through telehealth, Dr. Menn provides women's health consultations and patient education through many means, including her Instagram handle at Dr. Menn OB-GYN, which I have been passionately following for a while now and advise everyone to do so to open their mind to what goes on in the life of a breast cancer survivor and with regards to menopause. So Dr. Menn, I'm so grateful to have you here to talk about this important topic, and very, very excited. We know that for many women, just surviving breast cancer is a very small part of the journey. And it wasn't until I started listening to you that I opened my mind to, oh my God, but what beyond? And just the very treatments that help her prolong her life, impact her quality of life in so many ways by inducing menopause. So thank you for this. And I would like to start with some basics, if that's okay with you.
Absolutely.
Because for many of us, just the thought of estrogen receptor, positive and negative, and what does that mean when we talk about breast cancer?
Well, first of all, thank you so much for having me and elevating this really great need. I call it like a menopause black hole, because the average woman facing menopause, even just general premature menopause that does not involve a cancer diagnosis, those women really have a hard time getting care. So once the breast cancer, diagnosis enters the picture, most physicians, their eyes just like glaze over and they're like, no, we can't talk about any hormones. But I think it's really important to tackle this very first question that you mentioned, is the differences between the different types of breast cancers based on receptor status. And what I often say to patients and doctors is that breast cancer is heterogeneous, meaning it's very different in each individual woman. And I always tell women, your breast cancer is as unique as your fingerprint, right? And that involves, kind of the stage you were diagnosed at, the type of breast cancer. Is it ductal? Is it lobular? Is it ductal carcinoma in situ, et cetera? But then these receptors, and these are the big markers on how we diagnose and treat breast cancer. So typically we're looking at estrogen receptors, also progesterone receptors, right? As well as something called HER2 overexpression. But the most simple form to categorize these breast cancer patients are those that are estrogen receptor positive and those that were estrogen receptor negative, or people will say hormone receptor positive, hormone receptor negative. And that's really, really important because it dictates how we treat them and how we're going to talk about their risk of recurrence. And when we talk about receptors, particularly estrogen receptors with a breast cancer patient who's newly diagnosed, I always want her to know she has estrogen receptors on every cell of her body. Her normal healthy breast tissue has estrogen receptors. A 12-year-old girl who's going through puberty, all of her breast tissue has estrogen receptors. But so does her brain and her skin and her gut and her bones and her muscle and every other organ and tissue in the body. So if you get diagnosed with an estrogen receptor or hormone receptor positive breast cancer, it does not mean that estrogen caused that breast cancer, but it does tell your doctor that, okay, here's one way, a very important way that we can manipulate that cancer cell, target that cancer cell, and treat it. And so, yes, sometimes the treatment for, or most often the treatment for estrogen receptor positive breast cancer is to either block those receptors, manipulate, downgrade those receptors. But that's very, very different than telling that woman that estrogen caused her breast cancer, right? That's number one. And then also keep in mind, about 20% of women will be diagnosed with estrogen receptor negative breast cancer. Most typically, we call it triple negative. That's if it's negative for estrogen, progesterone, as well as HER2 receptors. HER2 is not a hormone receptor, but just a receptor that if it's positive, it shows that the cells are a bit more aggressive, and we can target it with targeted medications like Herceptin, right? But when we're just talking about the hormones, estrogen receptor positive or estrogen receptor negative is just a really important thing to understand. And most women are told this, right when they're diagnosed, but nobody explains how that may affect down the road her options for hormone therapy.
Mm. And I think this is so important what you brought out, that just because you have estrogen receptors, it does not mean that estrogen caused it.
Yeah.
Because anyway, estrogen has such a bad rap when it comes to breast cancer.
Yeah.
And we can come to that later. But you also mentioned the having estrogen receptors gives us an opportunity to manipulate treatment options. And could you explain some of those treatment options? Like,
Sure.
how do we really work on those if
Yes.
if a woman is positive?
Absolutely. So yeah, 80% of women will present with estrogen receptor positive breast cancer. And then depending on whether they're already naturally menopausal, they're already in menopause, or if they're premenopausal, there's different ways that we can target that. So if you're premenopausal, so under the age of 51, or you're still having your menstrual periods, we can do a number of things. We can just use something called tamoxifen, which is a selective estrogen receptor modulator, or SERM. And all tamoxifen does is block those estrogen receptors so that your own estrogen can't get to those estrogen receptors. And so tamoxifen works on different cells of your body, but for breast cells in particular, it blocks those estrogen receptors. Tamoxifen can be used whether or not you're in menopause or not. So younger women who are low risk for recurrence, less aggressive disease, they don't have lymph nodes that are positive, they can be given tamoxifen alone. If they're a little bit more higher risk, or they have positive lymph nodes, more extensive disease, they will often be offered ovarian function suppression. So we will give them a medication that stops their ovaries from producing any estrogen, and also give them tamoxifen. So lowering estrogen production, as well as blocking any estrogen receptors in breast cancer cells or breast cells. And then the third way we can deal with premenopausal women is to do ovarian function suppression, and then give them something called an aromatase inhibitor, which basically takes menopausal levels of estrogen and makes it go even lower. And this is important for women to understand, because aromatase inhibitors don't act like tamoxifen. They're not just blocking receptors. What aromatase inhibitors are doing is taking, an ovary, even in menopause, produces very, very low levels of estrone and some other estrogens, but also produces testosterone. And so aromatase inhibitors take the enzyme that converts testosterone to low levels of estrogen and blocks that enzyme. So women who are on ovarian function suppression, or they're already menopausal because of just natural menopause, or they've had their ovaries removed, when we give them aromatase inhibitors, I like to say it's like super menopause, right? It's taking very low levels that may be like 10 or 15 picograms per ml of estradiol, and putting it close to zero. It's severe estrogen deprivation. And so in current guidelines for naturally menopausal women, typically we start with an aromatase inhibitor as first line. But those women can also be offered tamoxifen if they don't want an aromatase inhibitor or they can't tolerate it. And then for the premenopausal women, we have those three levels, like I like to say: tamoxifen alone without suppressing your ovaries, tamoxifen plus ovarian suppression, or aromatase inhibitors plus ovarian suppression. And women can elect, instead of ovarian suppression, which involves an injection, either monthly or every 3 months, they can elect to have their ovaries removed. And we see this a lot in women who are premenopausal and carry a BRCA1 or 2, so BRCA1 or 2 mutation, because they're at higher risk for ovarian cancer. So they're often, or they're recommended to take their ovaries out when they're done having, done with fertility. But it's a permanent surgical menopause. And I mention all of these things because all these different scenarios can have really significant impacts on how you feel with your menopause symptoms, but they also really contribute to chronic disease risk. So we always have to take care of and worry about those things at the same time as trying to give you effective breast cancer treatment. I believe we can do both at the same time, but a lot of times quality of life, symptom management, as well as like thinking about the long-term risks of this, kind of profound or early menopause, that's often neglected. And that's where I feel like the menopause specialist really needs to be up to date and understand this, because we have millions of women around the world using these medications. Some of them are quite young women. And what are we doing about, we may be treating their breast cancer really well, but what are we doing about all the side effects, right?
And so if you could walk us through some of the short-term and long-term impacts of inducing this menopause through some of these drugs.
Yeah. So the most obvious short-term impact is symptoms, right? So hot flashes, night sweats, as well as all of the long list of menopausal symptoms that you and I are always talking about: joint pain, muscle aches, dry skin, vaginal dryness, pain with sex, decreased lubrication, decreased sexual desire. Also a lot of mood and brain effects. So cognitive changes, increase in anxiety, mood changes, depressive episodes, for your heart, some heart palpitations. So those are some of the common, side effects or symptoms. But it's equally as important to talk about what are the effects on all of your organ systems in terms of like your chronic disease risk or longer term concerns, right? So the most common one that women are often hopefully told is about bone loss, right? So these medications do contribute to bone loss, and actually pretty rapid bone loss, with the exception of if you're already menopausal and you're only taking tamoxifen alone. It actually is a bit protective on your bones, right? Not as protective as estrogen is, but because tamoxifen is a selective estrogen receptor modulator on the bone in a menopausal woman, it actually is an agonist, or is promoting the receptor there, can protect the bone. But aromatase inhibitors, ovarian function suppression, or doing ovarian function suppression with tamoxifen in a younger woman, those are all very, very negative on the bone. So top tip is get a bone density early, as soon as you're diagnosed, so we know what your baseline is, so we can kind of monitor how fast you're losing bone. And women should upfront be offered strategies to kind of decrease that bone loss. That's often not done, and it's not until years later that she finds out she's already got osteoporosis now. So that's a huge problem that I'm very concerned about. The other big health risk that we have to talk to women about is heart disease, right? It's the #1 killer of women worldwide. And for women who survive their breast cancer, right, in those first, let's just say the 5-year survival, you get past 5 years, you're more likely, frankly, in most cases, to actually down the road die of cardiovascular disease, right? So we always have to be thinking, are our breast cancer treatments hurting her heart health? And the answer is generally yes, they are. It doesn't mean you should be scared of these breast cancer treatments. I want you to get them, but we need to be equally concerned about if we're curing women or keeping them, disease free for decades and decades. We better care about her heart, right? So, ovarian function suppression or any kind of early menopause, we know raises your risk of all cardiovascular diseases, from stroke to heart attacks to atherosclerosis. really, really important to recognize that. And that's in the general population. So anybody who goes through menopause early is at an increased risk. So what I tell my breast cancer patients, like if you go through menopause early and on top of that, you're getting other breast cancer treatments, you're kind of, really adding to your risk. So it's not just the low estrogen state. Aromatase inhibitors are making that estrogen state even worse. And many of these women are also being given chemotherapy or radiation to their chest wall, et cetera. And those things can be accelerating heart risk. So we really need to be concerned about that. And then there's just chronic disease risks, in general, also from metabolic changes. So when we induce early menopause, but also some of the metabolic impacts of aromatase inhibitors and tamoxifen antagonize things like insulin sensitivity, glucose metabolism, raises the risk of diabetes, of fatty liver, of weight gain, of basically metabolic syndrome, right? And so again, another reason why we have to be proactive, because that has so many other downstream effects. And this can sound overwhelming, I know, but we can't help women if we don't name the problem. So telling them that there's full body effects to these cancer treatments, and we've got to be very proactive. And between the side effects and these risks, this is a reason why some women may down the road want to have the conversation. Oh, I hear hormone therapy is beneficial for a lot of these things. Well, what about me? Can I get a benefit from that? And that's what we're talking about today. Like, how do we choose and how do we counsel those patients that when they're done with their treatments, could they ever consider the benefits of giving hormones back, right? And that's the big question.
Absolutely. And I think as providers, so often we get caught up in survivorship, and the woman gets so caught up at that point in time.
Yes.
Right? She's been faced with the diagnosis of breast cancer, and the goal is, how am I going to get past this? How am I going to survive this? That not many women would be at that point thinking about what happens beyond.
Yes, of course.
And as providers, sometimes we are caught up in that and not able to allow her to see the path ahead. And of course, it's not probably the time to discuss maybe options of hormone therapy then, but at least to guide her that she will face these or may face these problems up ahead because of premature menopause. And that's I think that's so important. That's an
we
important
can have
message.
a plan, though. The thing is like, even when women are in the middle of 5 to 10 years of ovarian suppression or these medications, there's so many things that we can do that do not involve systemic hormone therapy. But what I find, honestly, in my own practice and frankly worldwide, when I hear from women, is that those things are not even being done. And so a very important message, if anybody's listening to this, you hear all these risks. And I want to say, you are not doomed, but you must be proactive, right? We can't ignore, I say, the elephant in the room, right? This thing that we don't want to talk about. We can't ignore it. And if we can start proactively with non-hormonal options, the pillars of lifestyle medicine, and we'll talk about today local vaginal hormones, how we could, at the very least, prevent and, treat and manage genitourinary syndromes. And we can be proactive with lifestyle and non-hormonal options for all the other symptoms. If we could give women that hope up front, all of this will not seem as daunting.
And that's such an important thing that you said is you're not doomed.
Oh no!
And yes, I think that and to be hopeful and looking at you, you don't look doomed at all. So
no,
so that is inspiring.
Well, yes, but I will tell you, I'm a 24-year survivor. I had stage 2 estrogen receptor positive breast cancer, and I didn't have any help for all of the side effects, the collateral damages, or the premature menopause, because it was 24 years ago, and frankly, menopause was not on anybody's, agenda. The Women's Health Initiative had just been released. There was no training really in my medical training on how to help the average woman in menopause. And so I was just feeling grateful to be alive and to be treated, that I was like, I'll just deal with all of these things. But while I looked okay on the outside, on the inside, for years, I did not feel good. And it wasn't until later, where I got myself educated, that I realized, wow, there's so much that I could have done for myself, and could have done better in so many ways. And so now that's my message to women. We don't need to wait years for suffering. We could be proactive up front. And we just need to be honest with women that we can't lump someone who has DCIS with someone who has an advanced estrogen receptor positive breast cancer, and we can't lump her with someone who is a triple negative or an estrogen receptor negative breast cancer who has survived more than 4 or 5 years, and likely that triple negative breast cancer is unlikely to recur. And we never used lowering hormones in, say, a triple negative breast cancer case to treat her breast cancer. So why, if she's suffering from menopause, can't we have an intelligent conversation about her options? The thing is, we can, but those conversations are not generally happening for women.
No, absolutely. Thank you for sharing that and sharing your story and being, for all your work. It's commendable how you've put your story out there to help so many women to be hopeful. So thank you for that. But talking about the hormones now, like let's get into hormone therapy. And if you're
Sure.
looking at systemic hormone therapy,
Mhm.
you mentioned estrogen receptor negative women. Would that be an option for them, taking systemic hormone therapy?
Sure. I think it's an easier option for us to discuss, right? It gets a little more complicated with estrogen receptor positive, and we can talk about that. But for triple negative or estrogen receptor negative patients, right? Really important, the mainstay of therapy for these patients is obviously their surgery, chemotherapy, often radiation, but chemotherapy, and now also different, immune mediated medications, some targeted therapies. But the bottom line is that for these women, blocking estrogen or lowering estrogen levels is not part of their treatment because their breast cancer doesn't express the estrogen or progesterone receptor, right? That's why we call it estrogen receptor or hormone receptor negative. And it's really important to recognize the challenges, triple negative patients face is that they are more aggressive cancer, and if they are going to have a recurrence, that recurrence tends to happen within the first 3 or 4 years of having that cancer. So we're generally very cautious in those years, and we're giving her all the therapies I mentioned. But once she gets past that 4 to 5 year mark, okay, those patients are very, very unlikely to have a recurrence of that particular cancer. And unlike estrogen receptor positive breast cancer patients, someone who is an estrogen receptor negative, it is very rare if they ever did have a recurrence for that recurrence to be an estrogen receptor positive, right? The other thing to mention is that particularly for young women who are diagnosed with ER negative disease, so women under the age of 40, a significant proportion of them are likely to carry particularly a BRCA1 or maybe a BRCA2, but much more commonly a BRCA1 mutation, probably almost 30% of them. And so those women are having their ovaries removed generally by the time they're age 40, sometimes even earlier, right? But the reason the ovaries are being removed is to prevent ovarian cancer. Because if you carry the BRCA gene, you're at high risk for breast cancer, but you're also at high risk for ovarian cancer. And so removing those ovaries does a great job of lowering your risk dramatically of ever having ovarian cancer. But the problem is now we're plunging them into surgical menopause, sometimes at a very young age. But it's not to treat their breast cancer. It's just to lower ovarian cancer risk. And so why can't we discuss hormones? Because in these ER negative women, once they finish their chemotherapy, some of them might lose their periods and lose ovarian function, either temporarily and then it returns. And if they're older, they can lose it permanently. But if they lose it temporarily, typically their periods come back. They may go on to have 5, 6, 10 years of normal estrogen production, right? And then at some point in time, they go through natural menopause, or they have their ovaries removed if they're, say, a BRCA carrier. So we have to kind of step back and think logically. If these women had years of normal high estrogen production, why now is it wrong if she's suffering to consider a low dose of menopausal hormone therapy to alleviate symptoms? The answer is it's not wrong to consider that. And in fact, those patients are actually, I think, ideal candidates to have with shared decision making, saying like, hey, this is something that is highly unlikely to increase your risk of recurrence. I would always want to know if she still had her breast tissue, if she was an estrogen receptor negative, and if she still had her breast tissue, I want to make sure, are you a high risk, patient who maybe carries a genetic mutation? So I'd want to know that and, counsel her on her risk of a new breast cancer versus a recurrence, right? But these are women where I feel like even in the US, I see even with medical oncologists who are informed and up to date on this, I find that there is an acceptance and more discussion that, yeah, we need to talk to these women about this because many of them tend to be younger. So they've got many years ahead of them and they may be suffering with a lot of symptoms. When you're an older woman, not old, but you're older than the natural age of menopause, most of those breast cancers are estrogen receptor positive. They tend to be less aggressive. Young women can have estrogen receptor positive disease as well. But I just feel like this is a young population that is a significant number that really we should be able to have these conversations about HRT. So to me, that's kind of, I call it low hanging fruit. I think that's pretty easy to discuss in those women. And then the other low-hanging fruit we should just get out of the way is understanding that vaginal hormones are different than systemic hormones and that all breast cancer patients, no matter what your estrogen receptor status, can use proactively and for treatment of the genitourinary syndrome of menopause. But many women are denied even that. And hopefully your listeners know that vaginal estrogen, low dose, is not systemically absorbed in any significant amount that would cause recurrence or cause breast cancer. And we have really good data on that. But what I see is a lot of misunderstanding that if you're in the middle of chemo or if you're taking tamoxifen or if you're on ovarian suppression or aromatase inhibitors, that you can't have it. But that's not true. And we actually have lots of professional medical guidelines that tell us that that is very, very safe. And I'm sure you get a lot of questions about that.
Absolutely, absolutely. And I think that's I'm glad you got it out of the way
Yeah.
because that is such low-hanging fruit. And
Totally.
the recent guidelines, I think the 2025 American Urology Association guidelines
Yes.
spell it out so well.
Yes.
But there is usually a concern about the use of low-dose vaginal estrogen with aromatase inhibitors. And could you tell us the difference? Like, why is there a concern with aromatase inhibitors but not with tamoxifen?
Absolutely. So when you're on tamoxifen we know is very effective regardless of whether you're in menopause or not, right? And tamoxifen is blocking estrogen receptors. Its job isn't to lower estrogen levels, just to block them. The concern with aromatase inhibitors, and I understand it, the whole point of aromatase inhibitors is to take menopausal levels of estrogen and put it in the basement, make it basically zero. So there's fear that any small amount of estrogen absorption could negatively impact recurrence or mortality. But the good news is we have modern vaginal hormone options that are different than what was used in the past, which tended to be a little bit higher dose vaginal options. And we can safely give it. We do have data. Now, some of the international guidelines are a little bit more conservative. So the British Menopause Society in particular they're much more cautious. But in the US, the Menopause Society, the American College of Obstetrics and Gynecology, the American Urologic Association, as well as the American Society for Clinical Oncologists, all of them agree that with shared decision making, that these women on aromatase inhibitors can have vaginal hormones and that the data does support it. Most of the studies done on women using vaginal estrogen after breast cancer, more of those women were women who have already completed treatment or were on tamoxifen. The numbers are smaller for women who were on aromatase inhibitors, but none of the studies show an increase in mortality. There is one study, it was a Danish study, and it is full of problems. But I want to bring it up because it's the one study that everybody cites. And so it's really important to understand that you can't just cite a study. You have to look at what was the actual parameters. So in this Danish study that was published a few years ago that caused a little bit of alarm, it was a retrospective look back at women who would use some form of hormones after breast cancer. And they found that in the aromatase inhibitor patients that there was a slightly higher risk of recurrence, but not mortality. But when you actually look at the details, women were being treated with likely higher doses of vaginal hormones, more than double or triple what we would normally use. So they were using larger doses of estrogen cream, like 2 grams or more. And then they were also, this population of patients, they were treated substandard to today's guidelines. So in this study, women who were really high risk of recurrence, only those women were put on aromatase inhibitor. And the majority of the women were either on tamoxifen, and some of them didn't even get adjuvant endocrine therapy. So basically, the women who had an increased risk of recurrence were the ones on aromatase inhibitors, and those were the women who had a higher risk of recurrence in the study. So you can't make a correlation from that. And it was also, most of the women in the study were treated before we had things like looking at their HER2 positive or negative status, or whether they needed chemotherapy or not. So they weren't using oncotypes. So basically it was taking old patients using higher doses of estrogen and then trying to extrapolate that risk to today's patients who are treated. And so what I tell my patients is that all of the data suggests that vaginal estrogen does not cause recurrence. And in fact, there's recent very large study that showed there was a lower mortality rate on women who use vaginal hormones. And what we suspect could happen is that women are more likely to stay on their treatments, to complete their aromatase inhibitors, to complete their tamoxifen, because they're not suffering from the genitourinary syndrome of menopause. So if you're on aromatase inhibitors and you and your doctor want to be really, really careful, but you also want to treat your genitourinary symptoms, there's very low doses of vaginal estrogen that are safe. So I would recommend sticking with either a 4 microgram or a 10 microgram estradiol insert. So there's little tablets or little gel caps. There's also a little ring called E-string in the US that dispenses very, very low amounts, 7.5 micrograms, very low amounts of estradiol. And then there's a product, I don't know if you have it abroad, but in the US we have something called Intrarosa is the brand name, or it's a vaginal DHEA. And that gets converted in the cell of the vagina and the bladder to low doses of testosterone and estradiol, but it doesn't get absorbed as estradiol. So it's very, very low DHA doses. Very, very helpful. So those are ways to use it. And if you want to use estrogen cream or estradiol cream in a woman on an aromatase inhibitor, you can use, instead of using 2 grams or more, you can use a 0.5 gram, and you could target it just for the lower 1/3 of the vagina and apply it just say 2 or 3 times a week, a small pea-sized amount on the opening of the vagina and on the labia and just on that lower 1/3. And if we do that along with lubricants and vaginal moisturizers, women can really have such relief and actually never get the severe atrophy. But what I see is women are denied any of it, and then they come 4 years, 10 years down the road. They've not been able to have sex. They can't even have a pelvic exam or pap smears. They have exquisite pain, sometimes bleeding. The vulva and the clitoris has atrophied. And it's hugely impactful on their quality of life and their relationships. And many of them have recurrent urinary tract infections. So to me, that's completely unacceptable. And I think if a medical oncologist is really worried about it, I don't recommend them like following the serum estrogen levels when women are on just vaginal estrogen. But if you're that nervous, you can just follow her estrogen level and make sure it's not going up. And you can have a little transient increase in that estrogen in the first week or two, especially when the skin is really thin. So why would we want the skin to get so thin? Just treat it up front so that she never gets any of that increased absorption when they're very atrophic, right? And I think all breast cancer patients, when they're first diagnosed, they should be informed of this, because we can be proactive instead of waiting years and telling them they've got to use lube and moisturizer first and then only consider estrogen if things are severe. Why would we wait for things to be severe to treat? It doesn't make any sense.
No, yeah, you're absolutely right on that. And yes, so many options available here today in North America. Unfortunately, we are still only in conjugated estrogen cream days back in India, but it still is available.
But that's very effective. Premarin cream works great. And again, you can just use a little bit lower amounts if you're on aromatase inhibitor. But if you're on tamoxifen, use it as directed. A gram, you could do it nightly for 2 weeks and then go down to, 2 or 3 times a week, but make sure you treat inside and outside.
Right. No, absolutely. Thank you. Thank you for that advice. And coming to the use of estrogen, okay, we finished with low-hanging fruit, and I
Yep.
know we've used a lot of time, but
Yep.
some of the trials about the use of systemic hormone
Yes.
therapy for breast cancer survivors. I know two RCTs kind of stick out, the
Mm-hmm.
Swedish ones, the Habits and the Stockholm. And
Yep.
if you could educate us about
Sure.
what these trials had to say.
Yeah. So really important when we talk about hormone therapy after breast cancer in general, we've got a couple of ways we can look at the data. We have many observational trials, and there was over 20 of them. And observational data is not always as high quality as randomized controlled data. And all of the observational data, and this was data from a long time ago, suggested that there was not an increased risk of recurrence. So there were some randomized controlled studies that you alluded to. So Habits trial, Stockholm trial, and there was a third one called the Liberate trial. And a couple things to remember about these trials. They were going on around the time of the Women's Health Initiative. And when the Women's Health Initiative was stopped early because of misinterpretation, it also impacted these other trials that were going on in breast cancer survivors. And the Habits and the Stockholm are these two trials. And the Habits trial was stopped early at about 2-year mark because they saw a slight increased risk of women who had had breast cancer who were using HRT of having an increased local recurrence, so a recurrence within the breast, but not a distant recurrence or metastatic recurrence, right? And then the Stockholm trial was being done around the same time, and that actually did not show an increased risk. And what's really important to note that many of these patients, more than a third to almost a half of the patients in both the Habits and the Stockholm trial were still in the middle of their primary treatment of breast cancer. There was a huge amount of patients who were on tamoxifen at the same time, right? So these are patients who were early within their treatment. These were patients who were patients who were treated in the late 1990s, the early 2000s, way before we had any modern, treatments that we use now, right? Like immunotherapy, Herceptin, oncotypes, different surgical techniques, neoadjuvant chemotherapy. Some of the women didn't even have their estrogen receptors tested, right? So it's very hard to take the data from those studies and extrapolate it to today's standards. And neither one of those studies got enough participation, and they were stopped early to say that either one of them were statistically significant. So what we can say is that one showed an increased risk of recurrence, the other one did not. The Stockholm trial that did not show an increased risk of recurrence still followed these patients, even though they stopped being in the study. They still looked to see what happened to them. And at 10 years, those patients didn't have an increased risk of recurrence who used hormone therapy. And so what we're left with is very imperfect data. But what I like to point out is we have lots of observational data. We have 2 very imperfect randomized trials. And in none of these scenarios did we see an increase in mortality. And in all of that data, all of the women were treated suboptimally to today's standards. So I say worst case scenario, if we use those kind of, older ways of treating patients, there could be a theoretical risk of a local recurrence. And yes, there's a theoretical risk if you have estrogen receptor positive breast cancer and it's sitting out there in a bone or liver and it's many years later, that if you now give some estrogen, there is a theoretical risk that it can stimulate growth, particularly in estrogen receptor positive. But what I remind patients is that risk is correlated to what is your baseline risk of recurrence. So meaning, if you are an estrogen receptor positive patient who has a very, very low risk of recurrence, you had early disease, you were completely treated, you have no evidence of disease now, lower grade tumor, less lymph node involvement, those patients have a very tiny risk of recurrence. And you, as an adult woman who has a lot of symptoms, may decide for you personally, you're okay taking a small risk to because there's other benefits that you care about, right? So I think that's one. And then if I have a patient who is at a very high risk of recurrence, maybe she had ER positive disease and she had a large amount of disease, I'm going to be way more careful with that patient and say, we're going to lean into non-hormonal things from a systemic hormone therapy, standpoint. And, vaginal estrogen is always safe, but I'm going to be more cautious with them. So I feel like it's very important looking at this data and these studies to kind of try to put the individual patient and compare her to what all of that past data suggests. And then also remind patients that the type of hormone we give you is likely going to make a difference. In the older studies, we were giving women conjugated equine estrogen, which is not bad, is probably good. But we were also giving them synthetic progestins, where the newer way we give hormone therapy is with a progesterone that's bioidentical, that's body identical, and appears to be more neutral on the breast. So when I'm counseling women, I'm also saying we're going to use lower doses of hormones when we can, and we'll give you what you need for your symptoms. And we're going to try to stick with either estradiol alone or conjugated equine estrogen alone if you don't have a uterus. If you have a uterus and we're going to need to give you something to protect the uterus, we're going to give you a progesterone, not a synthetic progestin, because we think that's better for, your risk. And also inform patients that there are newer forms of hormone therapy that we're really excited out there, like conjugated equine estrogen paired with basodoxifene. In the US, we call it Duavi. And I think that's really promising because that estrogen is paired with basodoxifene, which acts similar to tamoxifen and blocks estrogen receptors. So I think that's a hopeful option in the future for breast cancer patients who want hormone therapy. And I'll mention that recently a study was published in women who have DCIS, and they were given Duavi, which is this comp of conjugated equine estrogen and basodoxifene, and it showed that their DCIS was not dividing as rapidly, that the markers on the tumor were cut in almost half. So there's a lot of positive momentum and interest in that as an option, as well. And then, whatever we talk about the data and the studies, I think women are smart enough to understand that the data is not perfect and we have to make decisions based on not perfect data, but that we can weigh benefits and risks and she can make an informed decision herself versus just telling her no, right?
And that is so important. What you said about the kind of hormone therapy, we kind of blanket them all together, bunch them up together, and say, hormone therapy. But Duaviv, as you mentioned, is available in North America, not back in
And also
India.
conjugated equine estrogen. I think it's as important. There's so much talk about, we love estradiol. Estradiol, bioidentical, tends to be really well tolerated. But for much of the world, conjugated equine estrogen is widely available, I assume. And we think conjugated equine estrogen alone has some protective benefits on the breast. And I always like to remind doctors and patients that in the Women's Health Initiative, people who took conjugated equine estrogen had a lower risk of dying of breast cancer, a lower risk of dying by almost 40%. That's pretty impressive.
There was also a randomized control trial in survivors using only conjugated equine estrogen, right? I think it was a small trial. Vasilipulocellin, it was a small trial of maybe 70 women or so, and there was a lower risk.
Yes. And so if anybody wants to look up all of these different studies, if you look, certainly I recommend the book Estrogen Matters. There's a couple of open access articles that anybody can access. One is called Menopausal Hormone Therapy After Breast Cancer. What does the evidence tell us? A consensus guideline. It was published in the Menopause Journal in January. I think that does a really lovely job of breaking down all of that we talked about today. We can put in a link into this for sure. So I think that's like a nice place to start. And also the Menopause Society here in North America recently published a practice pearl last July. It's very short. It's very easy for anybody to read. And it basically summarizes what we said, that we can't treat all breast cancers the same. We must confront that women want answers and that the data is mixed and it's not all bad. and that it really depends on the type of breast cancer. And the
Mm.
other point I want to make that's really, really important for shared decision making, it is basically universally accepted now that after a breast cancer diagnosis, a woman can choose to pause her tamoxifen or aromatase inhibitor, or if she's an estrogen receptor negative, just complete her chemotherapy. These women at some point are given choice to get pregnant, to have in vitro fertilization or other fertility, treatments to help them get pregnant, have a baby, even breastfeed, right?
Mm.
This is considered internationally an acceptable thing to do, all right? So if we give these women shared decision making and choice about having high hormones to get pregnant, why can't these women be given the dignity when they're facing severe menopausal symptoms or premature menopause or surgical menopause, or concerns about bone health, heart, brain health down the road? Why can she not have a discussion on low dose of hormone therapy in the right case, not for everybody, but in certain cases? Why can't she have consideration for that? And to me, it comes down to, do we value women beyond their capacity to have a baby?
And that is such a profound thing to say, because we are not just carriers. We have a
Yes.
life beyond. And
Yeah.
most of us, 40, 50, and we've gone beyond. And it's like, it's your 2.0. And if there's no quality left to that life, where does it leave that woman? And,
Yeah. Yeah.
yeah. What about testosterone therapy? Is there any evidence about use of testosterone?
So, I wish we had better evidence, but this is how I like to think of it. We have some data in, the literature where we're looking at hypoactive sexual desire disorder. And in Australia, there is an approved testosterone for low desire in women in general, not specifically for breast cancer patients. But from that data, we've learned that it doesn't appear that low dose for low desire, I'm giving back a little bit of testosterone, that doesn't appear to have any negative effect on breast tissue. There's no association with increased breast cancer rates. We do have a lot of data in the trans community for gender affirming care on the use of testosterone for trans men, right? And that there's not increased risks of breast cancer there, right?
Mm.
And then I also will remind patients and doctors that lowering testosterone levels to severe degrees is not part of the treatment for breast cancer, okay? And some of these women particularly have surgical menopause. Their ovaries have been removed, so that we know right off the bat their estrogen is extra low compared to a woman who had natural menopause. So I think it's reasonable, after making sure you've treated women with vaginal estrogen, make sure they're not having painful sex, and you've addressed other, psychosocial aspects of sexual desire, that it's not unreasonable for women to do a trial of testosterone, understanding we don't have big trials in women who have had breast cancer. But if we're only, say, using some testosterone and we're not giving them systemic estrogen, it's very easy to watch their testosterone level. We can draw estradiol levels to make sure the testosterone is not being absorbed in too large amount that it would convert to extra estrogen. And we can give her a trial for 3 to 6 months and see, has this helped your sexual, desire and your function? And if so, I think it's not an unreasonable thing for her to do. We are not talking about pellets or large doses of testosterone. We're talking about using low amounts by the international guidelines for desire. So we have less data on it, but in many ways, it seems, again, kind of low-hanging fruit, that it's not something that is so unreasonable or dangerous that we can't consider it. Because again, women deserve to also feel like they have a healthy sex life. And there are some non-hormonal medications for desire, but they don't work that great, frankly. And the ones that do are quite expensive and not available in other places, like bromolamine and fulbanserin. So I'm very comfortable offering that to women. Again, especially once they're out of that initial window of diagnosis, they've got their treatment behind them. I think it's something that we can consider.
Wonderful. Thank you.
And that paper that we mentioned, they
Yes.
actually discuss all of that, the consensus statement, which is really nice.
Right, yeah, it's a brilliant paper. I really enjoyed reading it. It's a great summary of everything all put together. As a takeaway message, any pieces of advice that you would like to leave our women who are considering, breast cancer survivors who are considering hormone therapy, or not even hormone therapy, who
just want to manage
are looking for
menopause.
hope. And yes, exactly. Yeah.
Top line, you're not doomed. You've got this, but you have to be proactive. I tell my breast cancer patients, we all women should be doing the pillars of lifestyle medicine: exercise, excellent nutrition, good sleep habits, sense of community, working on all of those things. But you have an even bigger reason to do it, more motivation to do those things. So I can give you an estrogen patch, but if you're not doing all of those lifestyle things, we're not going to help you. So that has to be the cornerstone. You must demand of your doctors to spell out all of your health risks from your breast cancer treatments and your premature menopause. You must identify them. Don't be afraid to find out your bone density. What is your heart health? Know what your body composition is, know what your blood lipids are, and do a symptom list of all of the menopausal symptoms. Don't be shy. You have to tell your doctor all of the things you're feeling. That's the first part. And then know that we always can treat you with vaginal hormones, that we do have non-hormonal options that can help you with hot flashes and night sweats. You should never suffer with those symptoms. And there's other things that we can do for other symptoms, right? So that's a lot that we can do right there. And women don't even get that. And then if you do those things and you are still having a lot of concerns or symptoms, menopausal hormone therapy is not off the table. It just needs to be discussed in a very individualized way. So I tell patients, it's not a hell no, but it's also not a hell yes. It's somewhere in between, depending on your individual cancer, right? And you have so much power, and you don't have to fix it all at once, right? Pick one or two things that really bother you, start there, and then build on that. And, within a year or so, you can really reclaim your life. Don't be afraid.
And that is a very powerful set of tips that you've left our audience to. And what I hear from this conversation is that individualized shared decision making is what every woman deserves,
Yes.
more so when she has had breast cancer. And as providers, we need to be able to provide that individualized shared decision making and educate ourselves about it. And yeah, that's a lot to take away. So
Yes. And
thank you.
also, please be on the lookout. We'll both share it on our social media that we are trying to, get a kind of an observational or a perspective study, really, where women of, all types of breast cancer, whether you choose to use hormones or not, can be followed. We're calling it the MenopauseWize trial. And we're hoping to start to collect the data from the really millions of women around the world who are considering some form of treatment for their menopause, whether it's non-hormonal, hormonal, vaginal only. We want your data. We want your doctors to participate. So please be on the lookout in the coming weeks to months. We're really going to be promoting how everyone around the world can start to contribute to this data, because we need better answers for our survivors. We need to have real data to guide them.
Absolutely, and that is amazing. And thank you for this kind of work. And I think if anyone is looking for answers, it would be great to be part of this trial, so that we can help women for our future, and present and future. So thank you so much for this work. And for all of you who are listening, Dr. Corinne Menn is on Instagram, and she shares a lot of valuable information there, helping a lot of women across the globe. Her handle is Dr. Menn, OB-GYN. That's DRMENN, OB-GYN. Yes.
Yep.
And so, yes, thank you so much for all of this information, and looking forward to the MenopauseWize trial. And I hope we have many more women enrolling for it. And thank you. Thank you so much for today.
Absolutely. Thank you for spreading the word and all the work that you do.
Thanks again for tuning in to MenopauseWize. Stay informed, stay empowered, and I'll see you in the next episode as we continue to navigate the menopause journey together. If you're a healthcare provider interested in collaborating with us or have insights to share, we'd love to hear from you. Please email us at info@menopausewize.com. That's wise with a Z. And before we go, a quick medical disclaimer. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. always consult your physician or a qualified healthcare provider before making any decisions regarding your health or any medical treatments discussed in this podcast. While we strive to provide accurate and up-to-date information, this podcast does not replace professional medical consultation, diagnosis, or treatment. If you have any concerns or symptoms that require medical attention, please seek advice from your healthcare provider.